Thank you, George, for your inspiring address and for giving us much to think about as we work together today to advance the recommendations that the committee put forth. Important context for us to keep in mind today and in the future as we move forward. So good morning, everyone. I'm Laura Ayupa. I am a Senior Program Officer on the Board of Healthcare Services at the National Academies of Sciences, Engineering, and Medicine. I had the privilege of being the study director for the consensus report and the honor of working with a very dedicated and brilliant committee of experts, many of whom are here today to share their knowledge about burnout and well-being with all of you. In the next session, the committee will present the report recommendations, their findings and recommendations, and that will be followed by a discussion with audience members in a question and answer format. Now it is my privilege to introduce the study co-chairs, Dr. Christine Cassel, who is a senior advisor on strategy and policy and professor of medicine at the University of California, San Francisco, and Pascale Carayon, who is a Leon and Elizabeth Janssen professor and director of the Wisconsin Institute of Healthcare Systems Engineering at the University of Wisconsin-Madison. I will ask the committee members to join us at the table here, and we look forward to the next session. Thank you.
Yeah. All right. Thank you, Laura, and thanks to the Academy and the Collaborative for hosting this wonderful meeting. I was sharing with Victor before we started the observation, both of us being veterans of many Institute of Medicine and National Academy of Medicine committees and reports, how wonderful it is to have this ready-made implementation workforce for the work of this report. That's an unusual benefit, and listening to George's sort of grounding us in the profound importance of this issue, a much needed source of strength that we're going to need to really make this report have meaning and have legs. So we're going to begin by reviewing the report for those of you who haven't memorized it yet. And I'm going to get us started on doing that and then turn it over to Pascale. I'm assuming this, let me just go here. As both Victor and George mentioned, we see this report as being in the legacy of these really groundbreaking set of reports to Err is Human and Crossing the Quality Chasm, both of them released really around 20 years ago. So when you think about it, a huge amount of work and of progress and of both public and professional and industry awareness of the importance of patient safety and quality of care has emerged in those 2 decades. And in some ways, this report is kind of an essential next step to this process and to really making it possible for us to achieve the aspirational goals that were outlined even in that time. And look at this. Look at the numbers of sponsors. I don't know, Victor, is this an all-time record for the numbers of...
It's called retail fundraising.
Right. But this tells us 2 things. One is the widespread scope of institutions and individuals interested, concerned, and aware of this problem. The second thing is the potential implementation workforce that we have here represented on this screen. And both Pascale and I can testify that since the report was released, many, many more institutions and leaders have stepped forward and expressed their concern and their interest. These are the members of the committee. Not everyone was able to be here today, but I want to use this opportunity to point out two things. One is that when we say clinician, we really are intended, and the instructions to the committee were consider all healthcare workforce and all healthcare professions. We had on the report, as you can see, in addition to a number of physicians and nurses, we had Lex McNeil representing dentistry, and where's Lynn? Lynn Chrisman representing pharmacy. So pharmacy and dentistry have their own sets of issues, interestingly, as we learned in the course of the report. And then there are many other health professionals who are not represented in this report who also have impact on this problem and are impacted by the problem itself. What we found, though, is that if you look at the study charge, number one, as with all Academy reports, examine the evidence regarding the causes of clinician burnout and the consequences for clinicians and patients. There's very, very little evidence outside of medicine and nursing. That's where most of the research has been done. And even there, as you'll hear, it's not enough, and we need much more research. But in the other professions, there is just simply less clear evidence, and therefore very much a need for more study. The second task, examine the components of clinical training and of the work environment that can contribute to clinician burnout. So both the environment for learners and the environment of practice. Number three, identify systems, interventions, tools, and approaches to support clinician well-being, and propose a research agenda to improve the knowledge base. We held 4 in-person meetings. This did seem like a fast-track report, although I think probably for many of you, you were impatient for it to be completed. But we had a lot of activity, including a huge literature review. Even though there's a vast amount of literature, I think it's fair to say not all of it is 4-star quality, and therefore there was a lot of sifting through the literature. I want to particularly thank Laura and Mark Meisner, who's here, who really helped us with this extraordinary literature review, as well, of course, as the entire committee. And the recommendations that we came up with really were the result of consensus in the whole committee. And then an external peer review by 14 other experts in various disciplines related to the study. So as with all National Academy reports, this is the distillation of the very best thinking and analysis in the field. So what are we talking about here? I think definitions are really important as we start, and this in itself is something that probably needs more discussion and more study. But we looked at it from the occupational health perspective, and the World Health Organization definition of burnout as a problem associated with chronic workplace stress. It's not the same as a mental health diagnosis. It's not the same as depression. And that doesn't mean that there aren't relationships there, but it does mean that it's important that we understand as we look at approaches to the problem to think of it as a problem of the workplace. It's characterized by, as you know, by emotional exhaustion, depersonalization, and a low sense of professional efficacy. And it results from a chronic imbalance of high job demands and inadequate job resources. So that mismatch in all of the ways you can think about those two things, high job demands, which is always the case in healthcare, and inadequate job resources of all kinds lead to burnout. And we know that burnout is a major problem. As we heard from George, for all of the ramifications of it, it's also just plain and simple, a huge number of people affected. As you can see by these numbers, around half of our medical students, our residents, our other trainees, and our practicing workforce are experiencing burnout at one point or another. And the consequences are intense for both groups, for the clinicians themselves and for patients in terms of quality and safety, for healthcare organizations, turnover and the costs of turnover, and for society in terms of workforce shortages and inability to get the compassionate care that they need. So it really is a barrier to the triple aim, to better care, to improve population health, and to lower healthcare costs. And that's why many people now are talking about a quadruple aim, which includes clinician well-being. So now I'm going to turn this over to Pascale. I was very fortunate, and I think the report really demonstrates the value of looking at this from someone with expertise in systems science and systems engineering, and she's going to tell us more about that aspect of the report. Pascale.
Thank you, Chris. Thank you to all for being here, as well as those of you who are connecting with us on the webcast. And thank you to my partner and colleague and friend for giving you an introduction to our report. Taking Action Against Clinician Burnout is the first part of the title of the report. The second part is the systems approach to clinician well-being. Like Chris indicated, we're talking about a phenomena, clinician burnout, that doesn't have one factor, that doesn't have one solution, one intervention. And hopefully we're all on the same page in thinking about burnout as a multifactorial systems problem. There are many aspects of the work environment and the learning environment that really have to be addressed. And like George reminded us, this is really an interprofessional issue. And this is why that systems approach is so important, because it's not solving a problem for just one group, whether they're physicians, nurses, pharmacists, or dentists. It's really looking at the system and the care process, therefore looking at all of the members of the care team that contribute to patient care. Clinician burnout is tough. I'm not part of your healthcare system, and I'm an outsider. I realize the challenges that are in front of you, of figuring out how we are going to redesign clinical systems in all parts of our healthcare environment, whether it's at the practice level, at the hospital, outside of the hospital, interactions, interfaces between different systems, as well as the learning environment. Our review of the evidence, like Chris indicated, was very broad, more than 4,000 papers, documents, reports, and so on that we reviewed. Some of you may not be surprised, but some of you may be surprised that we don't really have a set of interventions that we can tell you, go and do it. This is the answer. Interventions need to address those system factors, the balance or lack of balance between job demands and lack of resources. And these interventions are going to take commitment. They're going to take commitment from all of you. And this is why you keep hearing us use that term of action, of taking action. And hopefully we get enough energy in the next couple of days that we can all get going on that road of action. So these interventions are going to take commitment, resources. It's not a problem that's going to get fixed by next year. So we're in it in a long term. This is going to be tough, and it's going to require changes at all kinds of levels, including our culture and climate. That importance of values and humanism that George was reminding us. So not a lot of evidence on effective system-level intervention, which, as some of us being researchers, is, I think, a call for action on our side to work with healthcare organizations and many other systems and organizations to try to address that deficiency in our evidence. And so the committee decided to go about it in a couple of different ways. One is by building that conceptual model that is really anchored in systems approaches that have been core to many of the National Academy's reports starting 20 years ago with the IOM report on To Err is Human and Crossing the Quality Chasm. The conceptual model talks about those work system factors that are really embedded in the structure, the organization, the fabric, the culture of what happens at the frontline care delivery, the shop end, if you want, what happens in terms of the healthcare organizations, the health systems, and also the external environment. And those three concentric circles that you see are not independent. They influence each other. They sometimes work against each other. And I think we want to take action so that they are better aligned and they better understand how they can work together to improve work system factors at the shop end. Sometimes the shop end seems very remote from maybe the external environment or leadership in our healthcare organizations and our educational institutions. But all of you who are in the outer circles of that model have really important decisions to make and to think about how you design and implement policies that would affect the shop end. The model also recognizes, of course, the importance of individual factors and those mediating factors that filter the way work system factors contribute to clinician burnout and professional well-being. Like Chris indicated, there are many negative consequences, unfortunately, of clinician burnout on the clinicians themselves, on the organizations that employ them or train them, as well as society at large, and of course, patients. The model also talks about a feedback loop, and this is really where action is important, to think about what can we learn, how can we improve. And again, being a systems person, being an engineer that deals with human factors and systems engineering, it's really important for me to tell you that this is not going to be a one-shot thing. There's not one solution. It's going to be an iterative process, but it is also a learning process. And so this is why you've heard from a lot of people this morning talking about humanism and the values and learning and participation of clinicians is really important. The work system factors. Think about it, I mean, I'm not sure I want to use the term checklist, but think about it as a set of factors that may be a roadmap. There's just not one. There are many. Of course, workload is a major issue. We hear a lot about technologies not being usable and not working for us. There is a lot that needs to be done in how we improve the usability and usefulness of health information technology, such as our EHR. George this morning talked about moral distress, so that misalignment of values between what clinicians think is really important to care for patients, and maybe other values that are in their organizational or external environment. So there are many factors in the work environment and the learning environment that can contribute to burnout. Whether these factors are relevant in your healthcare organization, if you're a CEO or a leader of a healthcare organization, I don't know, but that list provides you with a way of thinking about what are factors that you can look at and figure out how to implement interventions in your system. Of course, individual factors also are important, and George reminded us that individual interventions may be effective, they're just not sufficient. If you put people back into a system that has many of the job demands and lack of resources that we just talked about, it's not going to have a big impact over time. So, of course, individual factors are important, but think about how we can look at them in a systems viewpoint. Because our review of the literature and all of the input that we gathered from different groups and different people who testify in front of our committee, because that review, that analysis really didn't bring us a set of a short list of interventions. I think that was one of the bullet points in our task statement, is to provide that short list. Sorry, there is no short list. What we have is a set of guidelines, and those guidelines are again important for healthcare organizations as well as learning educational institutions. Those guidelines are categorized into three groups. The first group is values, systems, and leadership. And I think this is what I heard George talk about this morning. Of course, the systems approach is a key piece of it, and going back to that systems model that may help you to think about how to go about it. But values, humanism, professionalism, engagement of clinicians and patients in system redesign. Those are important values, and figuring out how do we align the organizational values with the way care is provided, the way care is organized and structured, and the way care processes are designed. And of course, leadership is really important. In our report, we talk about leadership, of course, at the top level, and the importance of assigning responsibility to a group of people for taking on actions against clinician burnout. But think about leadership at all levels of your organization, and how leaders at a unit or department level also have a role to play in addressing and reducing clinician burnout. The second category of guidelines for implementing well-being systems has to do with work system redesign. This is a set of principles that have been around in the literature on human factors and systems engineering, job and organizational design, and job stress for a number of years. And those principles are really important because they tell you the kind of the nuts and bolts about how to design systems so that you can reduce job demands and improve lack of resources. Meaning and purpose in the work that clinicians do is really important. You are in it because you want to care for people. How can we make sure that you have the system, the resources, the time, the team collaboration, and so on, the technologies that really allows you to do what you've been trained to do. interprofessional team, and so thinking about how can we design better team-based care to address clinician burnout. Those are some of the principles. Well, it's not enough to have the values, the leadership, the systems approach, and then those design principles. You need to move them into implementation. And our implementation principles relate to, of course, engagement of the clinicians themselves that are suffering from burnout and suffering the consequences of burnout, involving patients into those redesign efforts, and we're going to talk about that later today. And then very often I hear, well, Pascale, how can we do that? We just don't have time. And so, it's kind of that feedback loop of going back to those whole system factors, the commitment, the resources, and thinking about whether there may be things that we don't need to do. And so going back to some of the whole system redesign and figuring out how do we make human-centered design processes, methods, part of the fabric of how we go about designing organizational models, care delivery models, technologies, and so on. And of course, the organizational culture is really important. Figuring out how do we assess burnout, but not making the assessment itself a source of burnout. That would really contradict what we talk about in the report. And so having an organizational culture where people feel safe to talk about burnout and its consequences, as well as its contributing factors, and how we can move forward to improve it. So our motto is really to figure out how do we engage in that collective and coordinated action. And so for us as members of the committee that put together that report, it's a dream come true to be with all of you today and tomorrow to think about how we can work with you on taking our recommendations and then moving them forward. And all of you who are in different parts of healthcare, different levels, and all together, hopefully, we can address this important problem. Our recommendations were organized around 6 goals that are listed here on that slide of creating a positive work environment, creating a positive learning environment, reducing administrative burden, looking at technologies as a problem but also as a possible solution. Number 5, providing support to clinicians and learners. And goal number 6, investing in research. I'm now going to pass the floor on to my colleagues on the committee, and each of our 6 colleagues is going to address one of the goals on that list.
Great. Thanks, Pascale. I'll briefly address the first goal of creating positive work environments. The key overarching element here was to transform healthcare work systems by creating work environments that reduce burnout, foster well-being, and support quality of care. There were 3 sub-elements under this goal. The first was that organizations should develop, pilot, implement, and evaluate organization-wide initiatives that promote professional well-being and mitigate burnout. To achieve this, we have to establish the structure and process necessary to systematically drive change through the organization. And that requires executive-level leaders and their boards to commit to monitor and improve the clinical work environment. It requires organizations to create and maintain an executive-level leadership role and responsibility for improving and sustaining well-being across the organization. And this leader is required to coordinate efforts, design interventions that mitigate burnout, and promote professional well-being. The second component under creative positive work environments is to improve the balance of job demands and resources, as Dr. Carayon alluded to. This requires optimizing workload and task distribution through attention to teamwork, collaboration, communication, and professionalism. It also requires cultivating an organizational culture characterized by psychological safety and participatory decision-making, and aligning incentives, compensation, reward systems with professional values and the altruistic values of the healthcare professions. And the third component under this first goal is that organizations need to regularly measure and monitor both clinician burnout and the variables that contribute to it, and to then use that data to drive improvement. And this involves not only regular assessment of burnout and well-being, but also assessment of workload and the complexity of the work, use of that data along with input from the healthcare professionals doing the work to improve workflows, as well as transparent reporting of these metrics to hospital boards to foster accountability and to have oversight for our organizations to make progress. So I'll transition to hand things off to George for goal 2.
Thank you. So the very concept, thank you. Got it. Working. The very concept of learning environments is actually relatively new in the educational literature, where focus historically has been primarily on the content of learning, structure, teachers, all of the elements that go into learning. And this idea that the environment in which learning occurs can actually overwhelm all of those other things is relatively new, and there's not an extensive literature on it, nor even an agreed upon definition of learning environments. But learning environments, we've come to understand, are very complex, like working environments. They're made up of a social component, a community component, an organizational component, and both a physical and virtual space component. I got to credit Tom Naska and the ACGME, who more than a decade ago began to realize that in reviewing the programs that they approve for graduate medical education in this country, they needed to include a much broader look at the institutions and the environments in which the programs occur. So this is a relatively new field, but it is so relevant, and I think that the study and the concern about learner burnout has heightened the interest in it and the importance of it. So our recommendations to achieve this goal are first to develop, pilot, implement, and evaluate initiatives to improve the learning environment and support learner and professional well-being. We need much more information and data to be generated by our leading teaching centers, academic centers, schools, and their cooperating clinical entities to actually study what the components are, the social, community, organizational, and environmental, physical, and virtual structures, and to know in more detail what works and what doesn't work in order to improve those environments locally, but also to add to our information base about how others will improve that environment. That involves, in recommendation number 2, routinely assessing the learning environment and factors that erode professional well-being and contribute to learner burnout. This becomes now a responsibility of those in charge of those organizations that have the responsibility, and I would say the privilege, of teaching the next generation of health professionals, that they include in their regular reviews and reports what is the state of the environment in which learning is occurred. How are their learners doing regarding their well-being and their elements of burnout? I would say historically that has not been part of the reporting structure or of the expectation of the leaders of educational organizations. And we're making the very strong point that this must become core to their functioning. Third, these learning environments occur in a complex external environment full of accreditors, regulators, national educational organizations, health professions institutions, and other related external entities. The list was too long to name them all. You all know the alphabet soup and everything that goes into our complex world of regulating and accrediting, all of which is good and important for societal protection, but which sometimes can inadvertently contribute to burnout or fails to take the opportunity to support those steps to address burnout by making it a regular part of their review process and their accrediting process. So this, again, is a multi-factor system approach to improving learning environments.
Goal 3 is reduce administrative burden. And the text of the goal reads, prevent and reduce the negative consequences on clinicians' professional well-being that emanate from laws, regulations, policies, and standards promulgated by healthcare policy, regulatory, and standard-setting entities. These include payment policies, clinical documentation, quality measurement and reporting, prescription drug monitoring, privacy rules, pre-authorization, health information technology, and licensure, board certification, and professional liability requirements. Administrative burden diminishes patient care experiences and contributes to the risk of clinician burnout. These entities should engage clinicians and patients to identify and eliminate administrative processes that contribute little or no value to patient care. There are two specific recommendations under this goal, Recommendation 3A and 3B. Recommendation 3A is that healthcare policy, regulatory, and standard-setting entities at the federal and state levels should systematically assess laws, regulations, policies, and standards to determine the effects on clinician job demands and resources and on patient care, quality, safety, and cost. To accomplish this, assessment should be conducted before and after implementation, followed by modifications based on the results. We should use system approaches to minimize the risk of adverse effects on clinicians and patients, and align licensure standards and enable license reciprocity. Recommendation 3B is that these entities, in conjunction with healthcare organizations, should adopt technology-enabled approaches to documentation and reporting that incorporate human-centered design and human factors and systems engineering approaches. The goals are to streamline documentation for billing and quality reporting and to eliminate inefficiencies in certification and accreditation.
Why, when health IT has such tremendous potential to enhance our nation's healthcare to achieve the triple aim, does it appear to be one of the major contributors to clinician burnout and degraded well-being? Currently, clinicians spend far too much time using EHRs for lower value tasks that do not directly contribute to patient care. Most current health IT is less useful and less usable than desired. And electronic decision support, which has tremendous potential, too often fails to yield the desired behaviors, instead disrupting workflow and increasing workload. Despite nascent industry and regulatory efforts to improve the clinical value of health IT, these technologies remain difficult to use, time-consuming, error-prone, and a major dissatisfier for most clinicians. Strategies are thus needed in which all relevant stakeholders can work together to address the current challenges and support the new integration of exciting new technologies and approaches to allow us to achieve the quadruple aim. The committee came up with 3 recommendations. For the first recommendation, health IT vendors, configurers, and implementers should take a rigorous human-centered design approach that includes a primary focus on clinicians' and patients' actual needs with particular attention to cognitive load, workflow, and direct care tasks. Second, deliberate and persistent involvement of clinicians and patients in every stage of design, development, and deployment. And third, rigorous usability and safety evaluations based on established human factors methods. Further, regulators should establish, publicly report, and hold accountable vendors and configurers to complying with criteria for health IT effectiveness, efficiency, usability, and safety. Health IT vendors, healthcare organizations, and regulators should closely monitor implemented technology for negative consequences and address these promptly with pre-existing mitigation plans. And finally, policymakers and organizational leaders should create incentives to foster ongoing HIT innovation. Our second recommendation discusses the flow of information. The inability of clinicians and patients to obtain electronically stored health information remains a major source of inefficiency, frustration, and added cost to our system. Health information should be shared efficiently, safely, securely, transparently, and ubiquitously across electronic health records, pharmacy records, health applications, medical devices, and all relevant data repositories. The third recommendation is about a new system of health IT. Imagine a national, stable, secure, standardized, multi-vendor, multi-platform digital system that reliably assured the entire care team, including patients and families, can collect and use timely and accurate data to achieve the highest value care. A major goal of this next generation HIT infrastructure should be to allow clinicians to stay focused on optimizing patient and population health, while adjuvant processes and technologies derive the essential business, administrative, and research data necessary for a high-value care system.
Okay, thank you. The next goal that I'd like to share with you today is about providing support to clinicians and to learners. You've already heard these statistics several times today, but they're so important, I will say them again. Given that high prevalence of clinician burnout, up to 35% of nurses, 54% of physicians, and between 45 and 60% of medical students and residents have prevalence of clinician burnout. We also have high rates of depression among these same clinicians. For example, among our medical students and residents, many of them are experiencing symptoms of depression. So the committee created a goal that was about providing support to the recovery of those who are suffering. We want to make sure that we pay attention to reducing the stigma and eliminating barriers to help seeking, because they're such critical factors in order to improve the professional well-being of clinicians and of learners. There's 3 areas in here I'll talk about. First of all, providing support to clinicians and learners is about addressing state licensing board, health system credentialing bodies, disability insurance carriers, and malpractice insurance carriers should minimize the collection of clinicians' personal health information, either by not asking or by only asking for current impairments due to any health condition. Let me tell you a little bit what was behind that. Some organizations require clinicians to reveal past or current diagnosis or treatment for an emotional or mental health condition, despite there being no evidence that past or current diagnoses or treatment for emotional and mental health conditions increases the risk to patients or lowers the quality of care. So why do we ask for those pieces of data? The organizations listed above should be transparent about how they use clinicians' personal health data and be supportive of clinicians seeking help in order to improve their professional and their personal well-being. I know in the Board of Nursing, if you look across our nation, there is almost no standardization to our best evidence recommendations of how to assess nurses for licensure. That would be an important first step. Next, we think that state legislative bodies should create legal protection that allow clinicians to seek and receive help and support for mental health problems without the information being admissible in malpractice litigation. Doing so will help reduce the barriers for clinicians in seeking relief from their distress. We also believe that health profession, educational institutions, healthcare organizations, and training sites should identify and address the aspects of the learning environment, institutional culture, infrastructure and resources and policies that prevent or discourage access to professional and personal support programs for individual learners and for clinicians. It's critically important to identify and remove all aspects of the clinical environment that prevent clinicians and learners from accessing employee assistance programs, peer support programs, coaching programs, or any mental health providers. I'll pass the mic now on to my colleague Lottie Derby.
So as you heard earlier, we reviewed over 4,000 articles. This was really an amazing endeavor over the last 7 or 8 months. And through that process, it became clear that there was quite a bit known about prevalence, causes and consequences of burnout in physicians, in residents, in medical students, and nurses, but not so much about other very valuable contributing members of the healthcare team. So clearly, more research needs to be done. It was also very clear from our deep investigation into the literature that very little remains known about effective interventions, not only to help people recover from distress that they're experiencing, but also what are effective interventions in terms of mitigating risk in the first place. So that led to really goal number 6. It became very clear to us early on that we need more investment in research, particularly federal agencies, including AHRQ, NIOSH, HRSA, and the VA need to develop a coordinated research agenda by the end of 2020 to identify best measures of occupational stress, burnout, and workplace well-being in the healthcare environment, but also to determine the system factors that contribute to stress for clinicians and learners in all settings, and importantly, to test system-level interventions. And agencies should commit to funding and implementing this research agenda. Similarly, we also need to create opportunities for public-private partnerships to support research on clinician and learner professional well-being and burnout. And these partnerships should include health profession associations, foundations, payers, healthcare industry, healthcare organizations, health profession education institutions, and professional liability insurers, among others. It's also important that we really take a multi-pronged approach involving all stakeholders to address research barriers. This includes having healthcare organizations prioritize clinician professional well-being, surfacing and testing new ideas, and importantly, sharing them so that we can accelerate innovation and pace of change in this space. So with that, I'd like to turn the mic back over to Chris Cassel.
Thanks, Lottie. All right, well, I'm just thinking, just hearing this incredible intensity of these recommendations and the complexity, I was thinking about an app, a meditation app I have on my phone, where when you open it up, it says, take a breath. So let's all just take a breath right now. What you've heard is really a lot, and it's a distillation of an enormous amount of material that went into that report. And it's really represented beautifully by this artwork. And I don't know how many of you have been wondering, what is all this weavy, colorful stuff in the background of these slides? It's actually a piece of artwork that came out of the collaborative's invitation to artists to represent artistically what the dynamics of burnout or the meaning of burnout. So this one is called Woven, and these are the words of the artist. It represents the intricacies, the layers, and the complexities of feeling burnt out. while serving patients. So it doesn't happen, this is such an important observation, it doesn't happen all at once. It builds over time. Each of these shimmering and different colored threads represent life and hope that's embedded in each provider, the spirit of serving and the belief that you will make a difference. All of these aspects woven together are the essence of the provider. So it's not, as Pascale said at the beginning, there won't be a one-size-fits-all solution. First of all, because providers aren't all one kind of provider and one personality type or one kind of person, but also because the factors influencing burnout are so variable and so complex. So I just want to say in closing, and let me just say I checked with our boss, Charlie, who assures me that because we're running ahead of time, we could begin to take some questions and comments from the audience before we take our break, and then we're going to have additional members of our committee up here to be able to engage in more discussion after the break. But so just as we conclude this section then, I want to point out that the very complexity that we've just been describing, the systems approach, and as the artwork represents, the complexity of each individual human being who's a provider and each individual human being who's a patient, all of that complexity could lead to finger pointing in many different directions. Well, this is a very complex issue. It's those people who really need to get to work, or it's this organization that really needs to take charge. And our hope and our message and our real belief in the power of this collaborative is the understanding that it's everybody's job and that we won't be able to solve this problem without everyone working both in parallel but also collaboratively together. And that's really what we're here today to begin. So let me stop there and welcome questions or comments from the audience. I think there's a live mic in the middle of the room and on this side and in the middle if people want to. Oh, good, Laura Lois.
Good morning, Lois Nora. First of all, my thanks and compliments. It's an extraordinary piece of work. Thank you. A second comment is just as someone who co-led the conceptual model group, I want to note with great applause the conceptual model that has come out of this. We were looking at a model that kind of described it, and what you have done in terms of putting it into a systems approach, I think is absolutely spectacular. We expected evolution, but I think this is extraordinary evolution. And finally, to the point that you made just now, Chris, about complexity, I think as we do our work going forward, thinking about the unintended consequences. A simple example for the learners, the conversation within the report about potentially moving to pass-fail, which reduces one kind of stress for our learners, and yet from experience with multiple medical schools, oftentimes increases a different kind of stress around national standardized exams. So just the complexity of the work ahead. Thanks.
Thank you.
Hey, good morning. Tina Sha, Wellstar Health System. I think we're really lucky to have this committee up here, and my question is sort of between the lines question. What with the process, whether it was something that you read or something that you discussed or an impact that the reading or discussing had on you, what was one of the most surprising things that came to you?
I'll open it to my colleagues here. Somebody want to? Yeah, Lottie?
I think what was most surprising to me is the complete lack of articles in pharmacy, in dentistry, in other members of the healthcare team. I mean, I think we'd been working pretty hard in our own little sphere, thinking about doctors and nurses, and recently thinking more about advanced practice providers who I work very closely with every day in my clinical practice. And then, certainly looking at nursing. And that was really sort of my sphere of thinking. So this was a little eye-opening in, the fact that we understand and know so little about our colleagues who are doing incredibly meaningful and important work across our healthcare system. So for me, that was a bit of a surprise.
Sharon?
And just as an extension of Lottie's comments, the fact that we've been looking at this problem somewhat in silos and not really thinking about the interaction of the different clinicians and disciplines as part of the solution. So that was a big takeaway for me and has influenced how I'm taking some things forward.
Neil, and then Matt, you wanted to reply? It looks like everybody does. Okay.
I think the biggest surprise to me was a better understanding of what a systemic approach means. As Lois pointed out, our original conceptual model is really a subsection of the current conceptual model. It's more the job demands, resources, and individual factors. And I think that although I'm speaking just for myself, I thought I understood systems approaches in a general way, but in terms of applying it to this problem, I only understand it recently after working with people like Pascale, Chris, the other members of the committee, Matt, who've lived in this world for a lot longer than I have. And I realize now this basically adds a whole other dimension to the kinds of questions we ask and the kind of actions and opportunities that lie ahead.
Matt?
Maybe this was more a disappointment than a surprise, but the almost complete lack of anything in the literature on interventions that do more than try and make the individual clinician more resilient. And even those were sparse. Now, I think we had to focus on what was in the literature. I think there are organizations doing more systemic kinds of interventions, sometimes not to improve burnout. That's a side effect, a beneficial side effect. But the absence of dissemination of those things done locally, I think, is hurting us all. And whether it's an absence of good venues for publishing systemic changes and quality improvement kinds of things, or just folks aren't doing it, we don't know because we can't see it.
George?
So I would say it caused me to reflect on why it's taken us so long to wake up and realize we have this problem. And I came away saying, where have we been? Why haven't we been paying attention? We, all of us, who've borne some responsibility for both educational and care systems. And it's really striking to me that this serious, serious problem, which of course is profoundly interrelated with other problems of our healthcare and education system, why it's taken us so long to give a clarion call.
Tait?
Just two minor. Neil's comment resonates with me greatly. I think the wisdom that Pascale and Matt and sort of this whole expertise of the field of systems engineering that we have to a large extent not incorporated into the design of our healthcare systems is remarkable. And I think, again, gives us an opportunity to accelerate progress by harnessing that expertise. But I think one of the other pieces that was very revealing to me, Vindal, a member of our committee who's not here today, is how engaged some of our healthcare payers are in this issue. And I'll say that built on a handful of interactions I've had with CEOs of major payer organizations over the last 18 months that, makes me think that stakeholders who we need to help solve this problem, who I thought would be the last ones to the table, are already at the table. And waiting for us to engage with them in a constructive way about how do we evolve some of these challenges that all of us as individual physicians see and feel, and individual organizations feel sometimes powerless to change, but that these folks are there, ready to partner with us to make some effective changes. And so I think that was really refreshing. Vindal brought brilliant insights, both from his time in government as well as involvement in Blue Shield, that was really revealing to me.
Okay, and Pascale, you were surprised.
So I'm a human factors and systems engineer, so I eat and breathe design, and so figuring out how you would allow me and my colleagues to tinker with your systems, with your technologies to improve them. That's kind of a dream come true for an engineer, and I think the report opens the door to that. But what was really interesting to me, and thanks to my colleagues on the committee and to Chris Cassel, the co-chair of the committee, is for us on the engineering and design side to understand values of compassion, of humanism, of transparency, of psychological safety. And so you have a lot to educate us, and we are really happy to hopefully have increasing opportunities to work with you. We have tools designs, but we need to bring together the tools, the design stuff with important values that drive patient care. So.
Okay, so now we have 3 people who want to make comments, and let's make sure we have time for that. Linda.
Thank you, Linda Clever. I want to thank all of you. Leonard Cohen is the one who said it's the crack that lets the light in. And you guys have been pounding at this and making some very important cracks to let the light into this situation that we're in. I just wanted to add perhaps 3 elements. One is we think so much as clinicians about not only the care of the patients, it's also how the illness or the condition affects their families. And I would just like to add families. The families of clinicians are ones who suffer. So the parallel between our awareness of patients and their families as they suffer, the families of clinicians are suffering also, the children and the partners and so forth. So that's one. The second is the terrific diagram with the external environment. There's another external environment beyond that I think that this country and around the world are really suffering from the circumstances of trust and truth and the entire social and political environment that people are feeling terribly burdened, and it's as if everyone's going around with a second-degree burn. You just touch them and everybody's very jumpy. And the third is another set of clinicians, which are physical therapists and occupational therapists and speech therapists. I would guess we know even less about. There is the complexities and all that weaving this tapestry, but there are many clinicians too. Well, thank you.
Thank you. All good points.
Hi, I'm Michael Weinstein, and thank you, yes, for bringing this together. And I'm hopeful that this movement can help change the way in which we heal in this country. The first young woman who spoke, talked about unintended consequences, and I just wanted to raise that again. And even thinking about the prior publications from this organization that really enhanced patient safety. At the same time, some of the enhancement of patient safety was folks fixing the data and cleaning up the data and changing the way we document to make sure that we have the appropriate case mix index and all of that. So yes, it was great work, but at the same time, from a systems point of view, how we implement is how we get the results that the system creates. And so I think it's a word of caution just to think about how each metric we want to look at and what we want to incentivize how that will truly impact individuals, groups, units, et cetera. And I would say the more we can take money out as an incentive for physicians, the better our healthcare system will take care of us. And we are both patients, clinicians, and healers.
Thank you. I really appreciate those comments. Let me just make a couple of observations as someone who's lived in that standard-setting world in between the publications of those original reports and this one, that the issue of measurement, public reporting, and systems responses to that is, as you point out, extremely complex. I think we did a pretty good job of diving into that in our report, but there are always, anytime you use public reporting and particularly attach payment to any particular metric, you're going to get teaching to the test. And there's lots, unlike this area, there's lots of data and lots of research showing that. And sometimes our payment policy and our policy world doesn't catch up with the reality of how that can be ill-serving, burdensome, and even backfire sometimes. So there was, and this might be something we can talk about afterwards, and Tait in particular, but if there's consumer representatives here, I'd welcome that too. There's a real tension between the hunger for public information about the quality of care and the quality of doctors and nurses that are treating patients. And I'm I understand that hunger. I'm really supportive of it. But we also know how as soon as things become, scorecards and rankings and the star systems and various other kinds of things, they almost begin to lose their meaning because everybody figures out how to get to the top or claim they're at the top or whatever. I mean, every hospital in this country has a billboard saying we're number one in something. So that is an important conundrum, and that is one set of stakeholders who need to be at this table. When I talked about finger pointing, I mean, we all need to figure out how to address this. So I'm going to take.
I think Matt had a comment, and then
now we have another one. So just these two more comments, and we'll finish up.
So I would assert that clinician burnout is a side effect of the system that we have designed, which had many good intentions. And as a device designer, we often tell our customers, faster, better, cheaper, you pick any two. And the same thing's going to be true of healthcare. And if we go gung-ho and fixing clinician burnout, there will be problems with safety and quality and efficiency. These are not mutually exclusive. They're closely interlinked. And so what this really requires is a broad stakeholder, high-level discussion about values. And that's what I came away with from this process of the committee, and Pascale already said that we had been talking early on that as human factors engineers trying to fix the system about user-centered design. And then we started saying, well, really it should be human-centered because user doesn't capture it. But now I think at least the two of us are talking about human value, and maybe we need to use George's term, humanistic-centered design. But there needs to be a values discussion between our patients and society and the press and the government, the payers, everybody about, well, what's important, and if we do this, how is that going to affect these various things, and how do we navigate those trade-offs and find the equilibrium that is right for everybody most of the time. And I think that's reflected in the report in a number of the recommendations about having dialogues and having, for example, policymakers think about, pilot, and really engage stakeholders before they make decisions, for example.
It's a wonderful comment, and I think when you dig into the deeper report, you'll find that the report expressly recommends against public reporting and ranking of organizations based on subjective measures of well-being. It does encourage transparency with those metrics within the organization. And to the extent we have objective measures of organizational characteristics that foster well-being, report supports those types of measures. It reports things like the magnet designation or the AMA Joy designation as markers of organizational structure, systems, processes to drive progress. But there was strong feeling across the committee that if we're taking subjective measures and we're publicly ranking organizations based on them, where reputation, payment, and other variables will be linked, there will be dishonest reporting, and there will be encouragement of people to answer their surveys in certain ways, because their livelihood depends on that organization's success. And that will be a barrier to progress. It will take us to the wrong place. And so while we need to measure this and we need transparency, and we want it to be honest to foster progress, not ranking for the wrong reasons.
And I think your comment to me also calls attention to the difference between intrinsic and extrinsic motivation. I mean, you are professionals, you clinicians in the room and on the webcast and all over the country and the world, you're professionals. And I have to say, as an engineer looking at some of the things that you do, of looking at your jobs and counting things, splitting things into small pieces, to me is a very strange thing that really goes against that idea of you're in it because of you want to care for people. And so therefore the systems have to be designed to help foster that intrinsic motivation, and things that are built on extrinsic motivation may actually produce unanticipated negative consequences. So I think we have Chris. We're going to try 1, 2, 3. Is that it?
Yeah, I said 1, and then I said 1, 2, and now there's 3. So we were ahead of time. We're now going to be behind time. But if everybody can keep these comments very short, then we're going to come back after the break and have more discussion. So we'll have a chance. Yeah. So let's just hear your comments, and then we'll keep the responses from the panel until afterwards.
Sure, I'm happy to wait until the next session too.
Sure.
So Chris Sinsky from the AMA, and thank you again for the report. It was wonderful. I've read every single word of it, and it'll be a tremendous guide for us going forward. I also think it's important for us to think about what might we be missing or where are the opportunities that we haven't caught on yet. And so I'm going to ask all of you to help me with my own thinking, and I'd love to have the wisdom of your group on this. I think we have a $3 trillion industry that is underperforming. And it is underperforming in large part because of the lack of teamwork, but the teamwork includes the clinical assistant in the outpatient setting. So the majority of healthcare is delivered in the outpatient setting. The majority of clinical assistants are either medical assistants or nurses, but primarily medical assistants. And we don't talk about that part of the workforce, but I don't see how we'll solve this problem unless we address the lack of well-trained clinical assistants. And as I go from health system to health system, almost always the first problem is the EHR, the second problem is we can't find and hire and retain medical assistants who are qualified to do the work. And so as we think together about how we're going to solve the problem, I think we need to really grapple with how are we going to solve that problem? Because I think we have a health system where the professionals are working at half power. And we're working at half power because of the lack of a sufficient clinical assistant workforce. So I don't know that you'll have the answers, but I invite you to help me think about that problem, because that's where I've been spending a lot of my time thinking, how are we going to deal with this if our clinicians are working at half power? So.
Thanks, Chris.
Hi, this is Cha-Cha Cheng with NIOSH. Thanks a lot to the National Academies and the sponsors for making this report happen, and of course, thanks to you for the tremendous recommendations and conclusions. I'm curious about whether you've thought about if there are examples of interventions and systems approaches from other industries and sectors that we could pull from for this. Emergency responders would certainly have very shared values and even working hours. Educators, social workers would have similar, shared values. Or whether this would really be groundbreaking and set an example that could be applied potentially to other sectors. I know, other sectors also have to deal with technology and creating positive work environments. So I think this could be a good example that could be used for others too.
So that's really a question for you, Pascale.
Yeah, or Lottie, I don't know if you want to comment on that. This is a really interesting question, and I think the lack of published evidence on interventions to deal with burnout is not only a problem in healthcare, it's a problem across. The effort that NIOSH and APA have put into initiatives related to work stress and health go back to 20 years, 25 years, and I think there's still lack of movement in really figuring out how do we tackle that problem. And so my analysis of the literature is that those interventions are lacking in all kinds of different environments. I think healthcare may have some unique aspects of that interprofessional, and then also how do we engage patients, caregivers, and then the families of the people, the team members in redesign process. I think that adds a layer of complexity, but at the same time of opportunity for figuring out good solutions that are good for everybody. So Lottie, I don't know if you want to comment on it. No.
I don't really have anything to add. I think your point is right on in terms of really limited intervention studies across the professions. But Matt, you have something else to comment?
So,
last question.
I'm sorry. Burnout is not a healthcare specific thing, and it's not 20 years, it's hundreds of years. I read books and papers about burnout going back to the 1800s with the Industrial Revolution. It wasn't called burnout then, but it was the same phenomenon. And though we weren't looking for it, we saw papers in our literature review of police, firefighters. Separately, I know of papers in air traffic controllers. And I'd also mention that this is not an American phenomenon either. It's an international problem. And regardless of what country or what specialty, there's burnout, but the causes are a little different, right? So anesthesiologists, which I am, have 50% incidence of burnout, but it's very different than the primary care physicians. And I think if you step back, it's fundamentally our conceptual model, and different entities, whether it's in healthcare or outside, have different factors involved, but it fundamentally comes down to leadership and culture and the structure of the work environment.
Okay, last comment, please.
Thank you very much. I'm Edith Mitchell, and I'm a clinical professor of medicine and medical oncology at the Sidney Kimmel Medical College at Thomas Jefferson University. I'm also past president of the National Medical Association. And I happen to give a lecture and discussions with about 50 to 60 postgraduate learners, residents, fellows, during the meeting of the National Medical Association, and it was regarding burnout. Many of the participants expressed to me that because of their racial or ethnic background, they felt that they were under more pressure than usual regarding burnout and well-being. And my question to you is, during the portions of the report, which was outstanding and excellent, did you notice any differences Or do you have any recommendations that may be according to gender or age or racial or ethnic background of the participant learner? So are there any comments, please?
Would you want to start on your published medical student data, and then I can say what's coming?
Okay, sure. So we've looked at issues with respect to various demographic variables in the research that we've conducted over the years, and also in reviewing the publications that informed the consensus study. And the picture really isn't clear, and it looks like it's very complex. So overall, if you look, for example, at medical students, their race or ethnicity, even their gender, is not an independent predictor of burnout in big multi-institutional studies after you control for a variety of other factors. But the story changes if their race or their background has negatively impacted their experience. So it's more around the learning environment. So if there are microaggressions or frank mistreatments, harassments, belittlements, whether that's related to race or ethnicity, it represents sort of a learning climate that's really suboptimal. And in those situations, we see that non-Caucasian medical students have a very high risk of burnout, depression, and poor quality of life. So it's a complicated story. It's not so much it's more about the experience that individuals have. We also recently saw the paper in the New England Journal about surgical residents and their experiences. And similarly, there have been other longitudinal studies that have shown that harassment, belittlement, discrimination is a predictor for developing depressive symptoms in medical students. So it's clearly playing a role. You want to add to that, Tait?
Yeah, just briefly. So in our most recent national study, we did look at the experience by race and ethnicity, and there will be a paper out hopefully soon. But I think to emphasize Lottie's point that it's very complex, and suffice it to say, despite many efforts over the decades, we still have a number of steep barriers to entry for different demographic groups into the profession, and that there's probably some selection effect that we're only selecting the most resilient individuals from different racial, ethnic, minority groups are the only ones that are able to even make it into medical school and into the profession in many of our healthcare disciplines. And so we sometimes see these really nuanced interactions where the physicians, at least in different minority groups, have more resilience and weather some challenges of the profession better, even though, as Lottie said, they're experiencing discrimination and unfair treatment. I think in the gender analysis, once you get below the surface, we've all seen these relatively simple sort of univariate type analysis reporting that women are at higher risk than men. Lottie and I have studied this together for almost 20 years now, and that is a very oversimplistic message. When you control for age and specialty, we have some data coming out on practice setting and then also adjusting for some other personal characteristics. That difference completely disappears. And so I think the notion that women physicians are inherently vulnerable or need, a greater amount of resilience training or something than their male colleagues, I think we should reject. I think we should acknowledge that there are some distinct pressures. Our work environments and work systems may not be well designed for today's healthcare workforce. Maybe they were better designed for a workforce of 40 years ago. But so I think, again, much still to learn, and it's a critical question that you raise, and I think we want to get past sort of the superficial answers and really understand those deeper answers, and how do we re-engineer both our selection and application process, the training process, and then the work systems so that a diverse workforce can thrive.
Okay, good. So now we're going to take a break, and we're going to come back at 10:30 and invite other members of the committee, and some of you will stay to engage in more discussion about all of this. So 10:30. See you then.